Okay.
Any music?
I think we're going live. All right, I think we're on. Good afternoon, everyone. Can you hear me?
Yes.
Yes.
Awesome.
Yeah.
Good afternoon. Good afternoon. We are live on our Facebook page here. Good afternoon. I'm the Reverend Charisma Jean-Marie, and I serve as the Director for Racial Justice Ministries at Scarritt Bennett Center. We're grateful for you to join us on our live Facebook as we host the conversation Living in a Pandemic with our esteemed panelists today. There's an old saying in some African-American communities that is often applied to the broad stroke disparity of the nation's economy. The saying says, when white folks catch a cold, Black people get pneumonia. The saying really points to the ways in which hardship in our country often means death to Black and Brown communities. While the coronavirus is not a respecter of persons, anyone and everyone can be infected at any time. Everyone is at risk. Yet, it is important to note that disproportionately, the most vulnerable communities to be affected by COVID-19 is the Black and Brown communities all over this country. And let's be clear, this is not a case of bad decisions, unhealthy eating habits, or even bad behavior of Black and Brown brothers and sisters. No, this is systemic.
Yeah.
And that is why this conversation is important today and why we were very intentional about our panelists and what they bring to this discussion. Their expertise and professionalism and their love for justice and people have led us all right here on our Facebook Live. Beloved, it is my honor to welcome you to our live discussion. Here's some housekeeping rules. During the discussion, we welcome you to post any questions you have on your comments there, and we will try to answer any questions, all of the questions you have in this hour. Without further ado, it is my honor to introduce our facilitator for the hour, my brother, friend, and co-laborer in these streets, the Reverend Keith Caldwell, President of the NAACP Nashville branch and pastor at Keith United Methodist Church in Murfreesboro, Tennessee. Welcome, Keith, and I turn it over to you.
Thank you, Reverend Charisma Jean-Marie, and thank you for what you do at Scarritt Bennett and also in the Nashville and broader community. So again, we are delighted to have our esteemed panel. We're going to ask that each of you take 5 to 7 minutes to just kind of say who you are and what brings you to this work. We want to begin because we are so honored and delighted to have Dr. James Hildred. He's the president of Meharry Medical College, an expert scientist, among many other things. Dr. Hildred, would you begin with the 5 to 7 minutes, please, sir?
Thank you, Reverend Caldwell. So I'm happy to be here. I'm here to try to make the science underlying the pandemic clearer to everyone so that we can make good decisions about how to keep ourselves protected. The virus that causes COVID-19 is called SARS-CoV-2. and it wasn't experienced by humans until December of last year. And what that means is that there's no pre-existing immunity to this virus. And that's why it's racing through the global population the way it is. Unlike other viruses that we've experienced for many, many years, this one, there is no prior immunity, and that's why it's having its way with the human population. It actually belongs to a family of 7 viruses. These are human coronaviruses that have been around since the 1960s. And as a matter of fact, some of its cousins cause common colds. 30% of the common colds that we get are due to another coronavirus that belongs to this family. And you might also know that 2 of its cousins, SARS-CoV-1 and MERS virus, caused pandemics earlier in this century in 2002 and 2012. So the receptor for the virus is found in many organs in the body, including the lungs, the kidney, the intestines, part of the brain, and many other places. And that's why the virus causes such severe disease. The disease that most people know about is called severe acute respiratory syndrome. That's where SARS comes from. And it causes our lungs to stop functioning. We get this severe pneumonia, and people are dying from this. But you also need to be mindful that it also shuts down the kidneys, especially in African Americans. It's causing blood clots in young people in their 30s and 40s. So people are actually dying of strokes who appear to be healthy and fit. And that blood clotting problem is causing them to get strokes and other kinds of manifestations because of these blood clots. The thing that I'm really concerned about, and you've been reading about, is that people who have underlying conditions, including hypertension, asthma, heart disease, and obesity, get severe disease and are much more prone to die. We knew this from China because China is a racially homogeneous nation, but even in China, after the first month or so, they were reporting that if you had any of these conditions, and also if you smoked, you're more likely to get severe disease and to die. So we could have predicted, and it was quite predictable, that African Americans who have such a disproportionate burden of all of these things would have a very difficult time with the SARS-CoV-2 virus. I need people to know that only about 1.5% of all Americans have been tested for the virus. And that means that there's 339 million people out there or so who haven't been tested, many of whom are negative. And that means the virus will keep spreading through our population until one of 2 things happens. Until 70% of us are immune through a vaccine, or until the virus has infected that many of us. And clearly we don't want that to happen because there will be many millions of people who would die. So until and unless there's a vaccine, we individually need to take the steps we need to take to protect ourselves. And those are the following. Washing your hands frequently. There's nothing you could do more important than washing your hands several times a day. And that's because we have a habit as humans of touching our face many times during the day, especially the eyes, the nose, and the mouth. And that's what's called a T-zone. So washing your hands is a way to make sure that if you can't break the habit of touching your face, that you're not going to contaminate yourself with the virus. That also means that when you're in a place where there's surfaces touched by many individuals, those surfaces need to be sanitized many times per day to reduce the chance of virus getting onto those surfaces. The other thing to do is to wear a face covering when you're out in public. A mask is preferable, but if you can't have a mask, wear some kind of face covering. And if we all do this, we can break the chain of transmission. And that's because if you have the virus and you're wearing a face covering, you'll keep it from spreading to others. And if you don't have the virus, wearing the face covers keeps you protected. And that brings me to a very important point that I need people to understand. The more we learn about this virus, the more clear it becomes that we've never experienced a virus quite like it before. Because if you stand in the presence of a person for 10 minutes or so, with no signs at all that they're infected, they could well be infected and give the virus to you just by breathing in the same air that they've expelled without coughing or sneezing. And that's very unusual. We haven't really seen that before, except perhaps with measles, which is really, really contagious. So that being the case, there not being a drug to treat the virus, not having a vaccine, we all need to take the steps that we need to take to protect ourselves. And by doing that, we protect each other. And what I've been advocating for and pushing for is We need to have a concerted, deliberate, intentional, aggressive testing campaign in the African-American community so that we can identify the positives, take steps to get them treated or isolated to protect the population. Because we live in multi-generational households with older folks living with younger people. And young people can get the virus and do just fine. But we know for a fact that if you are elderly and have one of those conditions we've spoken about, your chances of surviving the virus, quite honestly, are not very good. So we need to take the steps that we need to take to keep the virus out of our communities. And that is why Meharry was so quick to set up an assessment center and why we're doing everything we can do to keep the virus out of our communities. Because if we don't do that, we're going to lose lots of our sisters and brothers. But I just need people to know the virus isn't going anywhere. It's going to be with us for a while. So let's take the steps we need to take to protect each other and protect ourselves. Thank you, Reverend Caldwell.
All right, thank you, Dr. Hildred. And our next panelist, we're going to ask Dr. Irie Lynn Sessions. She is a womanist theologian and also co-pastor of the Gathering in Dallas, Texas. So, Dr. Sessions, would you please speak?
Thank you so much. Again, I'm honored to be here. My role, my part in this panel is to talk about the faith crisis, anxiety that many of our people who are experiencing, and to also sort of respond to the question of, can we still be the church while social distancing? I just want to begin by saying, certainly we have heard countless times during this pandemic that the church is not a building, nor is it confined to a building. The church are people who have accepted God's invitation to be the change Jesus modeled to the world. The church are those people who have said yes to building the beloved community. And I just recently, through the Dallas Black clergy agenda, have had conversations about not just building the beloved community, but building the beloved economy, right? Yeah. But the church are those people who have said yes to doing that work. We are a community characterized by love of neighbor. Now, as Dr. King said, that love is not anemic. It is not docile or otherwise lacking in power to subvert oppressive systems that inhibit human flourishing. So yes, we can, and many are being the church in this season. A guiding question for us as we think about our own level of anxiety and concern, and rightly so, because there is a need for concern. I do think, though, a guiding question for us needs to be and can be is, have we built our hope on things material, or have we built our hope on things eternal, as the song says, hold to God's unchanging hand? And I think we are finding, as we examine much of our own anxiety, some of it has to do with what we have built our hope on, what we have really grounded our faith in. And in many cases, it is the material. And when I speak of this kind of building our hope on the material, I'm not speaking of just the Black church. I'm speaking of Christendom in general. That I think what we're being called to do in this season is to reimagine and to reflect and to rethink what it means to be a follower of the will and way of Jesus Christ in this season. So while there is anxiety, while there is need for concern, as the good doctor just explained to us, there are things that we can do to minimize that anxiety. There are precautions that we can take to minimize that anxiety. And we are called in this season, for those of us who are pastors, to really be pastors, to be concerned about the entire human being, right? Not just the spiritual part or the spiritual condition of the people who God has called us to serve, but the physical, the psychological, the emotional, all of those parts of who we are. And so we have a big challenge, and we're being called to be church and to be pastoral leaders in ways that we have not really had to delve into the way we have to do now. And so another part of my question is, how can practicing social distancing be a form of spiritual discipline in this season, right? So we find ourselves in shelter in place or stay at home, and it's challenging for some of us. Some of us are type A people, and we're movers and shakers and used to being out and about and doing things. But what can we do in this season in terms of building our own spiritual muscles, right? And allowing this season to be an opportunity to practice spiritual disciplines. And one of the things, I see this as an opportunity for us to listen to God during this quarantine, right? Although God did not cause COVID-19, and I want to be clear about that. Because, we hear some people saying, God caused this, that God brought this on us so that we could X, Y, Z, right? I don't hold to that theology. Although I do believe God did not cause the COVID-19, I do see it as an opportunity for us to really see the systemic injustice that is really being laid bare for everyone to see. The question is, do we have eyes to see? Do us as clergy people have eyes to see the systemic injustice, the real need for a livable wage, the real need for universal health care, the real needs? Are we seeing it? And if we see it, are we positioning ourselves in such a way that we can be a part of the solution, that we can do something about what we see? So I see this as an opportunity for us to listen to God and to see and to pay attention. Also, I heard just this morning, Dr. Melva Sampson, who is a practical theologian and homiletician, she said COVID is the disruption of a system. So these systems have been disrupted, habits have been disrupted, even traditions have been disrupted. And so what do we do with these disruptions, right? So I see it as a time of reassessment, of reimagining, and of resetting ourselves and asking the question, how do we really want to live out the remainder of our lives? And I think this is a time for us to make those kinds of decisions and to think about those things.
Thank you so much, Dr. Sessions. Our next panelist would be Reverend Mahisha Hassan. She's the Executive Director of Movement in Faith in Memphis, Tennessee, and a professor and many other things. Reverend Mahisha Hassan.
Thank you, Keith. Always good to share space with you and my beloved Dr. Irene Sessions and all of those I'm meeting for the first time. And I'm just glad this space is being made. So my voice, even though I wear a lot of hats in the world and I tread in many places, my voice in this space is coming from my deeply rebel side, my rebel side that wrestles and labors for freedom with and on behalf of my people. And so I'm going to get into just a little bit of historically, where we are coming from, where we are, and where we can go, what we can still do. We have never been a people without power. And so what can that power look like in this moment? So structural racism is persistent and pervasive. And like I said, has historically been so for people of color, and to be specific in my context, Black people. So just like every other aspect of oppressive people and policies, systems and structures, COVID-19 has shined a very bright light on what has already been present. This is not a new place that we tread. And so to be clear, this bright light has always also been shined directly by people who are directly impacted by the oppressive systems and structures, oppressive people and policies. Flint still doesn't have clean water. So while we out talking about washing our hands, what do we do when the water's not clean? We've seen where folks are like shelter at home, but what do you do when there is no shelter? So all of these conversations come up when the direct things that we are given to do, we don't have equitable access to and have not historically because of these disproportional things that we keep talking about, the lower birth rates and labor complications in Black women, the levels of imprisonment of Black people, the access to healthcare. Economic disparities are related and then impact every other part of the equitable distribution of resources. As Dr. Hildreth said, we are multi-generational households. And there's some communal and tribal and collective reasons for that. But part of that is also still economic, right? And then Dr. Irie is speaking about how faith is such a key component of our communities and how this factors into how we are expressing our faith at this time. And it also factors into how we are receiving our information. Because these are places that we are more likely to trust before we trust the government that has been shown to not be in our favor. So yes, I co-sign on both the tragedy and pervasive global pandemic that we're in, and also the opportunity to see what is laid bare before us and how we can be a part of making a world that is a better place for actually all of us. So I'm originally from Charlotte, North Carolina, and one of my friends, Cornell Wright, is the executive director of the North Carolina Office of Minority Health and Health Disparities there. And I say this in a funny tone, but he has been laboring for years and years, speaking on behalf of what it looks like for vulnerable populations, I would say populations made vulnerable, in revealing systematic inequities and widespread unshared power, But what is happening, the dynamic that is happening with him is now his phone is blowing up. Everybody wants to call on him. Everybody wants to hear what he has to say, but where were they before? He has been saying these things over and over. The people on these panels have been saying these things over and over. We have many and multiple voices in many spaces speaking on behalf of what is needed to have positive impact on our community, but very, all of a sudden in a Mike Jones way, back then you didn't want me, but now I'm hot, now you're all on me. So why is that? Why does it take a global pandemic for you to start listening to Black folks about Black issues? So the opportunity here is that there is a place for you. There's a petition that I was grateful to be part of circulating. I'm going to pull that up just so I can refer to it. And it's through the Action Network. I will put the link in our Zoom and then it can be distributed to everyone. And it's entitled Southern Governors Prioritize #Health Over Profit. It is geared toward putting pressure and offering encouraging opportunity to be in solidarity with Governor Brian Kemp of Georgia, Governor Bill Lee of Tennessee, Governor Tate Reeves of Mississippi, Governor Ron DeSantis of Florida, Governor Henry McMaster of South Carolina, and Governor Kay Ivey in Alabama. And I can get more deeply into some of that language, but I just at least want to give you the demands that are in place and how you can be a part of those demands, read the language, and support. Demands are an immediate rescission of the reopening of our states and reinstatement of shelter-in-place orders, safety plans for each state before they reopen that includes resources for PPEs for workers, real-time COVID-19 data disaggregated by county and race, and then increased public health model testing, tracing, and treatment with specific support to communities that are low income and communities of colors. And then the immediate expansion of Medicaid in each of our states. That's a whole nother conversation. And then enhanced unemployment support for residents that have lost jobs or not worked. So I can go further in detail when there are other questions and other times, and I will stop there for now to be in order.
Okay, so Mahisha, it's a way you can post that link here. Oh, okay.
Yeah, I'm gonna post it in our Zoom that we're sharing,
Okay.
and then whoever is feeding it to the live, if you could get it out to the people, I will do that now.
Okay, great, thank you. And our next panelist is Dr. Calvin Smith. Dr. Smith is Assistant Professor of Internal Medicine here at the legendary Meharry Medical College here in Nashville, Tennessee. Dr. Smith, so glad to have you.
Good to be here, Reverend Caldwell. Thank you so much for the introduction. And so my purpose here is to try to talk just a little bit about the testing that's going on right now, what we're doing at Meharry Medical College to try to help facilitate the testing. So it is a collaborative effort between the School of Medicine, the School of Dentistry, and the School of Graduate Studies here at Meharry. We are doing testing, which is the street side testing, so drive-up testing on Monday, Wednesdays, and Fridays. And we are located right in the heart of North Nashville. We serve that community. My primary care clinic is actually located right there in North Nashville. And so we are serving that community. We're seeing about 200 or so cars per day. And, you know, within that, we're seeing multiple passengers in some of those cars. So we're seeing quite a few people, but as Dr. Hildred pointed out, this is just kind of a drop in the bucket. We need to be seeing more people. So I want to talk just a little bit more about, you know, who should be tested, what the testing is about, all that kind of thing. So the test that we are performing is a nasal swab. And so for those that have not had a nasal swab in the past, it's not the most comfortable test, but it is going to definitely be the most accurate in terms of how we obtain the samples. And accuracy is very important in this particular situation because the testing, as Dr. Hildred pointed out, this is a novel virus, meaning it was brand new. We've not seen anything like this before. So we're going to have to be very accurate in how we obtain the specimens and how we you know, hold them and send them out, et cetera. So the things that we're concerned with the test right now are two concepts, and I'll try to break them down as simply as I can. The sensitivity and specificity of the test. Sensitivity just points out whether the test is picked up or not, whether the virus is picked up by that particular test, and how much of that virus is needed for that test to be positive. Specificity points out whether this is looking at this specific virus or others. As Dr. Hildred pointed out, there are several other in the family of COVID or of coronaviruses, but we want to look specifically at this particular virus. And so the test that we are using has a high sensitivity and specificity for this particular virus. So that's the first part of it. Who should be tested for it is kind of a question that, you know, has generated some controversy, but our philosophy at Meharry has been we are testing as many people as possible, given the circumstances and given the number of tests that we have. So the first bit is, are you symptomatic, or have you been around someone who is symptomatic? Have you been in a high risk area? Are you a high risk patient? So the symptoms recently expanded. The initial symptoms that we were looking for were fever, cough or shortness of breath, and then fatigue or a dry cough, okay? The CDC just recently expanded that out to include one symptom in particular that is pretty specific to this, which is the loss of taste or smell, and a new loss of taste and smell, as well as diarrhea, aches and pain, sore throat, headaches and chills. So anybody that has two or more of those symptoms should really be tested for the virus. In addition, if you live with someone who is actively having those symptoms, or around someone for an extended period of time who has those symptoms, you probably need to be tested as well. And the reason why we're putting so much emphasis on testing is because this virus, again, there's so much going on with it that we just do not understand. But one thing that became very abundantly clear is how fast it acts. And especially those that have severe symptoms, it can act within 24 hours. Someone can be doing fairly well and then become severely ill and need to be treated with critical care. And when we talk about critical care, this is what is important about our social distancing, is that our resources at baseline for critical care were limited. But especially now, we are at risk of overwhelming our systems. And the people that have this severely need urgent critical care with ventilator support, dialysis, things of that nature. As it was pointed out by Dr. Hildreth, this virus is causing some clotting issues, which is one of the newer things that we have found from it. And this is because it acts at a particular receptor in the body in order to introduce itself. It's called the ACE2 receptor. And not to get too technical with it, but it is something that is pretty much everywhere within all of the blood vessels in the body. And so it causes the body to react violently to it, especially those that have severe symptoms. And so that violent reaction causes you to basically shut down. And so we need to treat it urgently. Now, as far as how, let's say your test comes back positive. If you have mild symptoms or no symptoms even, the most urgent thing for you to do is to shelter in place, to be quarantined, to stay away from people for at least 7 days. If you are symptomatic, then we ask that you shelter in place for at least 3 days, 72 hours after your symptoms have abated, without taking any medications or anything like that. So without having to take Tylenol, not having a fever, etc. If you are taking care of somebody who is sick, it's very important that you give the sick person their own space. Separate yourself, be in a different bedroom, use a different bathroom if you have to. Now, Reverend Hassan pointed out something that's very important, is that, you know, in a lot of our communities, we are forced essentially to share the same spaces, share the same facilities, you know, so a lot of this advice is not practical for those. If you are sharing facilities with someone, it's going to be urgent that you do everything you can to be in a well-ventilated place. So opening windows up, opening doors up, trying to move as much of that air as possible, circulated out of the room. So having a fan going, things of that nature. And you know, this is, again, we've not dealt with something like this before. It's very unprecedented, but you know, we need to be cognizant of those kind of things. If you start to develop severe chest pain, you start to have difficulty breathing, we call it worker breathing, having to use extra muscles to breathe, you shouldn't hesitate to go into a hospital for urgent support. And I want to be clear about that, because we've had a couple of people to come through our site who have had these severe symptoms and have been very reluctant to go in. But time is of the essence with this thing. It's like a heart attack. You know, when we deal with heart attacks, we talk about time being tissue. Well, time is tissue in this particular disease as well. So we really want you guys to those that are listening, those that are taking care of those that are sick, to have kind of a low threshold for when you need to come in. If you have a physician's number or a doctor's office number, call them, get advice from them. We are all here to try to minimize the effects of this disease on the population, but you know, we need to make sure that we are doing our due diligence in that regard. If you are someone who has a lot of risk factors like high blood pressure, heart disease, diabetes especially, you really should try your best not to be a caretaker for somebody who has COVID, because you are at increased risk of developing COVID. And you know, if you can't take care of yourself, there's no way you can take care of others. So I want to stress that. Dr. Hildreth pointed out the face covering, so I don't really need to talk about that as much. But I do want to point out that, you know, the fact that one of us has a face covering and the other doesn't puts both of us at higher risk. So I really want to put a point of emphasis on everybody, as much as you can, covering your face somehow, some way, because I call it a rule of two. It takes two to tango. It takes two people to transmit the disease. And so really want to focus on making sure that we are distancing ourselves. And if you can't distance yourself, then be safe. And with that said, I know I kind of went over my time, but I want to turn it back over to you, Dr. Caldwell, or Reverend Caldwell, and have a more discussion with the question.
Okay, thank you so much. And so Reverend Sharizna is telling me we've gotten a lot of questions coming in on Facebook Live. So we want to go around to each of the panelists. We had 2 questions that if we can just succinctly answer. The first one is, how do you respond to elected officials who are more concerned about the economic crisis over the well-being of their constituents? And the part B to that, and what is your perspective or even advice during this pandemic? Dr. Hildreth, would you begin, please, sir?
Well, I'm happy that in Nashville, our mayor has decided to use data to inform his decisions about how to proceed with businesses. And I've been saying that we are the economy. If you want to protect the economy, you got to protect us. We shop, we build, we drive, we are the economy. So if you don't protect us, in fact, you're not protecting the economy. And to me, this is about preserving life, and nothing is more important from my perspective than preserving life. And if we all value life equally, then that means that the people who lead us should be making decisions that are consistent with that. And another one of my problems, Reverend Caldwell, is viruses do not respect borders. They do not respect city borders, county borders, state borders. So we might do a fantastic job of controlling the virus in Nashville, but if the neighboring counties or neighboring states don't do such a good job, and we start going back to normal, quote unquote, we'll find ourselves in exactly the same spot we were in because the virus isn't going anywhere. The virus is still with us and will be with us until one of two things happen. We have a vaccine, or 70% of us are immune to the virus. And that can only happen if 70% of us get infected, and we certainly don't want that. So my thing is, if you really want to protect the economy, protect the people who in fact are the economy, and that's all of us.
All right, thank you. And so if we'll follow the same order, was it Dr. Sessions, were you next on that same order?
Yes, thank you. You know, one of the things I wanted to say in response to Dr. Hildred, or to build upon what he said, he mentioned about, you know, if we all care and value life equally, the problem that we see is that many of our elected officials and others do not value equally all life. In fact, there's one senator that talked about, you know, older people, in other words, should be okay with dying, right? To make room for their children. Well, that is not an ethic or a value or a spiritual principle that I value as a Black woman, as a pastor, as a human being, period. And so because we don't all value life equally, then for me as a pastor, it was important for me to collaborate with, to connect with other like-minded, progressive, prophetic pastors who are willing to put our theology, put our money, put our efforts on the line to confront these officials that do not value life and do not value our communities the way God will have them to be. And so what that means is organizing. What that means is writing. What that means is showing up in places when we can. What that means is doing things like we're doing right now to educate our community, going live, to pooling our monies together so that we as a community can help those who are in our communities who are in need. It is resisting, it is pushing back against those forces, against those systems that do not value all human life equally.
Thank you. Reverend Mahisha.
Thank you. I'm going to use my time to directly speak from the language of the petition that I hope is being circulated. So while you're watching this, engage with us and then pull out your devices and sign. So it says, Southern governors, we want to work. We don't want to die. We understand your desire to begin the process of reopening our states, getting more residents in our states back to work and boosting our economies. However, doing so without creating and articulating safety plans in the wake of COVID-19, without releasing real-time COVID-19 data that is aggregated by county and race, expanding Medicaid so that more of our people have access to healthcare, enhancing unemployment to protect those who have already lost their jobs or cannot work, and increasing testing across our states, especially for cash-poor communities and communities of color, is irresponsible and a death sentence for many of us. This is how we respond. Reopening our states without meeting these demands puts our communities in the unfair position of choosing between financially providing for our families and putting our families at risk of exposure to a disease that has already stolen the lives of hundreds and thousands of people. Because the states have some of the lowest testing rates in the entire country, those are some of the southern states that they're trying to reopen, the true risk is even greater than we know. And yet, even with limited testing, we know increases in both cases and deaths in these states are not flattening. And this is happening at an alarming rate, and particularly in Black communities and rural communities that don't receive as much attention. So our families, as Dr. Hildred said, we are the economies. So our families, our neighbors, our workers, all workers are not disposable. As Dr. Irie Sessions mentioned, our neighbors, relatives, members of our faith communities and co-workers are being put in an impossible decision, life and death decision, to prioritize profit over people. Many of our community members cannot afford to not work and either have not yet received the stimulus checks or received stimulus support and can't cover all the many needs of their families. So we demand that our elected leaders take the necessary time required to find solutions that are safe for our people and good for the economic well-being of our states. This is how we respond. Lastly, the Economic Recovery Group, I'm gonna be disgruntled, my tone, this is an industry representatives that should not be deciding voice in deciding whether businesses reopen. Their interests are clearly not in alignment with public health safety, nor do they actually include any medical health professionals in their process of arriving to the conclusion that now is the time for our states to abandon shelter-in-place order. Their stated goal, very clearly, is to prioritize the speed of reopening rather than the collective welfare of communities already impacted by disproportionate lack of access to COVID-19 testing and treatment. So we are people who believe that we should not have to choose between the safety of our people and the economic wellness of our state. We are people who believe that there are solutions that do not require us to choose between the safety of our families and having enough money to put food on the table. To put food on the table. This is how you respond. Use the language from this petition, and there is also an action toolkit that will come out that will give you actionable items and how to proceed in your local context. And we can go further into in any time off of this with who put this together, the groups that have already been on the ground and already doing this work that you can engage in and become active and consistently engaged to make this better for all of us.
So we're really thankful that this is a fantastic resource. One last question. The states that are choosing to open, if you look at it, it looks hauntingly familiar to a Civil War map.
Correct.
Is there a correlation? And if so, would you make the connection?
I mean, absolutely. This is the same Southern plan that has been used to disenfranchise voting, that has been used to mess up all kind of electoral maps, that has been used to oppress in any way possible. So there is not an equitable distribution of just fill in the blank.
Mm-hmm.
Fill in the blank. So this Southern plan is still in place, but Southern power is also still in place. Yeah. And I'm not talking about the raggedy white nationalism Southern power. I'm talking about power of people to move on behalf of our people. Still in place, still can happen, and you can be a part of that.
All right, thank you so much.
Mm-hmm.
And Dr. Calvin Smith, same question, please.
Sure. So a lot of the high points have been hit, but I want to talk real quickly about compassion and humanity. Because it's real difficult to put a financial value on a human life when you see people as human beings. And we need to get back to looking at each other and recognizing that we are human beings trying to live life, trying to have the same goals, go on vacation, enjoy family, do all these things together. But we can't do it if we don't value our own lives. And valuing our own lives requires some sacrifice sometimes. And this is the sacrifice that needs to be had at this particular point in time. I want to talk also about compassion and about the people that are in positions of power and their lack of compassion and what we can do about it. Because the thing about it is, these people that are making these decisions are elected officials. That means we put them in place, or we passively allowed them to be elected. And so I want to point out that we have the power to take back that power from them, and that goes into voting. To really look at it and have a close look at what the values of the people that we put in place are. And do they really care about people, or do they care about money? And if they don't have that compassion and that humanity, we need to exercise our rights on a local level, a state level, and a national level to get people in place that do care about us and care about people and don't just care about money and industry and things of that nature. Do we need these things? Absolutely. You know, we enjoy all of the luxuries of life, and we want to be able to enjoy our lives. But the cost of it should never be human lives. It should never be other human lives. And we've kind of lost touch with that. And not we in the sense of our community or those on this panel, but I mean the general we in the United States. When you go grocery shopping, you know, people that aren't obeying the social distancing rules, that just show a lack of compassion for the people that are working at the grocery store, people that are working in healthcare, people that are working in fast food, your janitorial services, things of that nature. They don't acknowledge the people that are doing essential jobs, these things that we call essential jobs. And you know, you become heroes. But I saw something that was interesting on Facebook earlier. It said when people start lauding you as a hero, that means that they're ready for you to die. And you know, that's kind of powerful. That, you know, that means that, again, you kind of are separating people from their humanity, and we shouldn't do that. We should allow people to be human, and placing economic value on people certainly is a dehumanizing thing. It's a couple of steps away from slavery, and we by all means need to be away from that. So humanity and compassion are the things that I'm calling for.
Okay, so Reverend Sharizna, I want to do a time check with you. Should we do the second question, or did you want to get to the Facebook questions?
Let's get to the Facebook questions. We have several.
I'll pass it over to you. Okay.
All right. We have several Facebook questions. I'm going to lean towards Dr. Hildred for this question here. This comes from one of our viewers. How do we build immunity for the virus when we are not to leave the homes or be around people?
Can you repeat the question? I'm sorry, please.
Yes. How do we build immunity to the virus if we're not around people, if we're home and we're not around people? How do we build immunity?
The two ways that we get immunity to viruses is we become infected by the viruses and survive the infection, or we get a vaccine. And the vaccine is going to be, at least in my opinion, 18 months away. So we are now trying to evaluate whether someone who's been infected by the virus and survived, whether or not they have become immune to the virus. And to be honest with you, there's no definitive evidence right now that being infected can in fact cause immunity, because in 3 countries, there are already reports that someone who was infected, cleared the virus, has now been infected a second time. And so that means one of two things. They weren't immune to the virus and after being infected, or there was a reservoir of virus in their bodies that has been reactivated. Both of those are very scary, but the bottom line is that typically there are 2 ways to get immunity: get infected and survive the infection, or get a vaccine. So that's, as far as we know, the only way that anyone can become resistant or immune to a virus.
The second question, Reverend Session, Dr. Session, it's a theodicy question. Why do bad things happen to good people? Where is God in all this? For those who are viewing us, who have faith traditions that speak to a God, where is God in all this?
Thank you. That's a good question and an expected question, actually. I want to begin by saying, first of all, where God is not. God is not in the politics of disposability, right? God does not believe, God does not set forth that some people are more important, more necessary than other people. So this whole notion of, opening up cities in certain parts of, or opening up states in certain parts of the country and opening up certain businesses, i.e. barbershops, nail salons, beauty shops, places where a majority of Black and brown folk frequent, these people are not disposable. There are no disposable people. And the other place God is not in this individualistic sort of way of thinking about life, me and mine. We serve a God who is concerned about collective and communal thriving, right? And so that's where God is not. God is, in fact, I believe, where God has always been. God is on the side of the oppressed. God is on the side of those in need. God is on the side of those we say who are marginalized, right? God is in the voices of those prophetic scientists, theologians, pastors, doctors who are giving us the clarion call of what we need to do to take care of the community. God is in that. God is in those people. God is not in the coronavirus. God did not start it, send it, or use it to create some greater good, right? But God is with us. And just because, and so we get this, I think, is a jacked up kind of theology that says, okay, God, if I do all the right stuff, if I do all this respectability kind of way of thinking about God, right? If I do all the right things, and I won't get sick, I won't die. My people I love won't die. Unfortunately, that's just not how it works. That's not how God handles God's business, right? But even in the midst of trauma, even in the midst of a pandemic, God is working and God is present. God is with us in our grief. God is with us in our pain. God is with us in our suffering. God is in fact suffering with us, I believe. And so that's where God is. And I hope that was helpful.
Gotta preach, Doc. Dr. Smith, there are questions about symptoms. You know, there are precondition issues that many of our family members have: high blood pressure, diabetes, and there's a new list of symptoms that came out. Can you talk a little bit more about precondition health concerns and the new list of symptoms that just came out that relates to the virus?
Absolutely. So as far as pre-existing conditions are concerned, you know, when you are a chronic carrier of a particular disease or a chronic, you know, dealing with something that has a long-term effect like high blood pressure, diabetes, it puts a strain on the immune system just in general. Particularly diabetes. Diabetes, we know for fact that diabetes lengthens the stay of hospital stays for people that are in the hospital. The healing process takes longer, usually more complicated with diabetes. Diabetes is a disease. When I teach my medical students, I tell them it's a disease. It's an endocrine disease. That means it's a hormone disease, but it's also a vascular disease. It's a disease of blood vessels. And so everything that has small blood vessels, like your heart, like your brain, like your eyes, like your feet and your hands, like your kidneys, are all affected by diabetes. And if the blood vessels are damaged, then they are already prone to being inflamed. And when you get a disease like COVID, which specializes in inflaming those blood vessels, it's a dangerous situation. So those that have those kind of conditions really need to be careful and be on the lookout, even for mild symptoms, because it can progress rapidly. Heart disease, to a lesser extent, we haven't seen so much in the way of heart disease, but it certainly does, like I mentioned before, put a strain on your immune system. And you know, it's showing that people that are young are able to deal with it, as Dr. Hildred pointed out. But even some young people are still having severe symptoms, and it's not discriminating. It's not picking and choosing, like saying, hey, you know, this person. I was watching the NFL draft yesterday. They talked about two different people who were both athletes who had wildly different courses with this disease. So we just don't know a whole lot about this disease. But what we're finding is that those that are at risk are at an extreme danger. As far as those that are I lost my train of thought here. We're talking about the disease being those that are vulnerable to the disease with the new symptoms. Okay, so with the new symptoms, it's not that these symptoms are new. It's just that we are now starting to recognize that these symptoms are present in more people than what we thought. And so anytime a disease comes out that is novel or new, if we can pinpoint something that is particularly specific to that disease, we want to do that. So the loss of taste and smell is a big one. There are not too many viruses or diseases out there that cause that specifically. And that's something that, you know, most people are eating and drinking every day. You know, obviously those that are sick have lost their appetite a bit, but you're still ingesting something. And that's something that you can be acutely aware of, losing your sense of taste or smell. As more and more people get diagnosed with it, we're seeing correlations with headaches and with diarrhea. We actually found that people that have diarrhea along with the other symptoms are actually having worse outcomes, because it's showing that there's involvement in the GI tract. And, you know, I have theories as to why that is, but, you know, nothing's really been proven yet, because again, this is a new virus, and we can't stress that enough. Everything about this is new. We've never seen anything like this before, and that's why it's calling for us to have unprecedented action towards it. Things that we've never done before, we need to do. So the symptoms aren't necessarily new, but they are things that we are now starting to correlate with that. And I hope I answered that question to a good extent.
Yeah. Dr. Hildred, more questions about the virus itself. What thoughts around the idea that this virus may not produce immunity antibodies to reduce reinfection?
So the question relates to why the virus might not induce antibodies to prevent reinfection?
Yes. Mm-hmm.
Not all antibodies that are produced to viruses are what are called neutralizing antibodies. These are antibodies that bind to the surface of the virus and prevent it from infecting cells. Great example of that is HIV. Every person infected by HIV makes antibodies, but it's very rare that in any one of those individuals, those antibodies are protective. And in some cases, antibodies are actually a bad thing. For example, in dengue, when people get infected by dengue and make viruses, antibodies to it, that actually can enhance infectivity rather than reduce infectivity. And the truth is, we need to do some experiments with the plasma from people who've been infected to really ask that question and get a definitive answer. But as you probably heard, the WHO just announced that based on the information they have, there is no evidence as of yet that being infected by the virus is enough to give you immunity. We have to wait to see if the antibodies produced are neutralizing. But as I said, in 3 countries that I know of, there are already reports of people who were infected and a short time later, after clearing the virus, they become reinfected, which would indicate that their antibodies did not protect them.
Thank you. Reverend Mahisha, a question for you. How can digital communities support more ethnic, honest support of vulnerable populations? Any best practices?
Digital support?
Digital communities support more ethnic, honest support of vulnerable communities. Any best practices?
Okay, so there are already so many people at work in these areas. So the best way to start is to plug into someone already at work, right? So not necessarily to build a new thing. And so that way you can collectively gather power that is already in motion, movement that is already in motion. And so, we at this point, we have all the hashtags and all the things. So I think for this petition, for this campaign response, if you will, to reopening some of these southern states, it's hashtag health over profit. So if you're going to post or do things, then line it up with something that's already in work that has a following of folk who are in line with what you are trying to move, and then share and reshare. But I'm a put some emphasis on, in this digital part of the best practices, is read what you are sharing before you share it. Like, actually do some analysis, do some fact checking before you go and tell people how to move, or before you go and create whole campaigns that are not in alignment with what other people are already doing. So if you look at the folks that put this petition together, go to their individual websites, reach out directly. So even though you're doing digital things, reach out directly to a human person or an email that's part of that group, and engage before you just go do a whole thing on your own. Just that's as a best practices. And again, there will be a toolkit which will include like media responses, local ways to get the word out, ways that you can also do this digitally in a way that we can't, touch and agree in the ways that we used to. And again, I'm not exactly sure of the timeline of that, but it should come out really, really soon. So there will be resources that are given to you, that are provided for you to do this work and to be able to organize collectively and be part of movement in this way and in this time. That's actually a really, really good question. And a lot of the folks who are doing the work are tuning into this. And so we can make sure that we can give you concrete steps on what that can look like, and you can just follow it down. Thank you.
Mm-hmm. One last question, we will move on, Reverend Keith. This one is for Dr. Smith. What treatments have worked well for your good patients?
Okay, so what treatments have worked well with patients? With viruses in general, yeah, it must be said that a lot of things in terms of viruses are supportive treatments. We can't really, unlike bacteria, where we can attack and kill those bacteria, we can't do the same thing with viruses. Viruses are raw DNA or RNA, and it's really extremely difficult for us to kill those things. And so supportive care is the biggest thing. And so in the vein of supportive care, medications that try to help bring down the fevers, medications like Tylenol, NSAIDs, aspirin, ibuprofen, etc. Those patients that have severe symptoms, we move towards trying to support them in whatever body part is being affected the most. So patients that are severely compromised in their kidneys, they stop producing urine, their kidneys shut down. We need to be able to do that for them. So we do dialysis. Patients that are unable to breathe well. So patients are coming in and they're struggling to breathe, but not only are they struggling to breathe with the actual work of it, their lungs just aren't doing what it's supposed to do. There's so much gunk and fluid and inflammatory process in the lungs that they're just not functional as well. So they go down to an 80% oxygenation level, which is not sustainable for life. Those people need to have ventilatory support. You know, for those that are having milder symptoms, the things that work for the flu, things that work for, you know, severe cases of colds tend to also work with this disease. But one of the other novel treatments that I've been reading about is in terms of treating people very early on with things that thin their blood, anticoagulants. We've seen a lot of good information out that this may be something that not only helps to reduce the symptoms of the patients, but also reduces what we call their morbidity or their quality of life after having this disease. So some of my colleagues have begun to give what we call high dose anticoagulants. When you go into the hospital, generally, if you have to stay in the hospital, they give you medications so that you don't develop blood clots from staying still in bed all day. Sometimes people get higher doses of those medications. And what has been tried, especially after autopsies have shown the clotting and things of that nature, is that we are giving people the doses that we would give for somebody who actually has blood clots. So giving higher doses of those medications has been shown to be supportive. I want to speak real quickly about one of the drugs that got a lot of mainstream attention, but it's actually has been shown to not be supportive. It's hydroxychloroquine. Hydroxychloroquine is a medication that is very effective for those that have diseases like lupus and other rheumatoid diseases. But it comes with a side effect in a large number of people of developing heart rhythms that are dangerous and incompatible with life, arrhythmias. The number one cause of death for people that have heart disease in general is to develop a bad heart rhythm and arrhythmia. And hydroxychloroquine is actually one of those medications that can prolong your heart rhythm to the point where it starts to get out of whack and have arrhythmias. So we have to, you know, I think it was a good point that was made earlier about the sources that we look at and how we use those sources. We really need to vet this information that we see. You know, there's so much information now on the internet, and to me, a little bit of information is bad. You have to have a lot of information, and you have to know what the sources are. A lot of people have an agenda behind what they're writing, and there's a lot of mistrust in the community, and rightfully so, because of things like the Tuskegee experiment, things like Nuremberg trials in Germany. But you know, the majority of physicians out here, Dr. Hildreth, myself, people that are at Meharry Medical College and worldwide in academia have taken an oath to do no harm to people. And we take that very seriously. And, you know, we no longer can see the horrors of people with polio, the horrors of people with measles because of vaccinations. Vaccinations eliminated a lot of those processes. So we don't have to see those things any longer. But I think as time has progressed, we have forgotten what that looked like. And so now it's like, you know, well, you know, vaccinations are dangerous. There's no evidence that vaccinations are actually dangerous to people to the extent that we need to stop giving them. So, you know, I wanted to speak to that point as well, because, you know, eventually it's all going to all lead towards, as Dr. Hildreth pointed out, there are two roads, either getting the disease or being vaccinated for the disease. There's nothing else that we can do to prevent people from getting this disease if they're exposed to it. And so we're going to have to reconcile with ourselves whether we want to continue to see what we're seeing now. And those that have had family members who have had bad outcomes with this disease will tell you it's not something to play around with. It's a rough process, and as much as we can do to alleviate it, we should. And I think I've kind of talked a little bit too much, so I'll digress.
Thank you.
No, I appreciate that. Actually, Dr. Smith, you answered my last question for Dr. Hildred, but I'll give him an opportunity if he would like to respond. There's a lot of comments on here about the distrust of vaccines. And you noted historically there's a reason why, and that was kind of the question. So you kind of answered that. I don't know, Dr. Hildred, I want to give you an opportunity to say something about vaccines. The specific question here is, why should we trust a vaccine? Would you like to make any comments about that?
Yes, we should trust vaccines because, as Dr. Smith said, were it not for vaccines, measles would still be ravaging people in this country and other countries. Polio is a great example. We don't have to worry about polio anymore. Measles is another example. Rubella, there's lots of things that we have to deal with that cause great morbidity and mortality except for vaccines. And I believe that we've come to a place where, for reasons I don't understand, people have stopped trusting science when they take science for granted every single day. The food we eat is safe because of science. The airplanes we get in without worrying about falling out of the sky is possible because of science. We'll let anesthesiologists put us to sleep with these poisons, trusting they'll wake us back up again. It's all science. So it is unfathomable to me that we trust science so significantly every day in everything that we do. But somehow when it comes to vaccines, which are proven over decades to be effective, that some people don't trust them. It's just beyond me. But I think that we're living in a time when, unfortunately, we have leaders who have taken it upon themselves to attack science and scientists. It's on display almost every time we watch one of the White House briefings, how much science has to battle with politics to get through. And that has to change. Otherwise, we're all in deep trouble.
All right, Keith, it's on you.
Okay.
Can I say one thing first? I posted this in the chat, but I want to say it. And I think what the Black community needs more of is what they experienced today on this call. They need to hear, we need to hear from our Black doctors and our Black scientists. Seeing on that panel with the president, a cadre of white doctors and white scientists, yeah, we don't trust them for all those reasons that we were given. But how can we see more of you? How can we hear from more of our Black scientists and Black doctors?
Dr. Hildreth, can I answer this?
Of course.
Because in my capacity, one of my capacities is as a clinician, but the other capacity I take very seriously is a newly appointed capacity. Is I'm the assistant dean of admissions for Meharry Medical College, and we need to have more Black doctors, not just from Meharry Medical College. Meharry and Howard still are the biggest provider of Black doctors in this country, but especially for our institutions. Dr. Hildreth has done a wonderful job of, and I'm gonna toot his horn for him real quick. He's been on NBC, MSNBC. He's been reached out to even by Fox to talk about this information and to make it accessible to people. And you know, I can't tell you how many of my friends and family members have watched him and have said, thank you for somebody that can put it in our language and also show compassion and care. But yes, you speak to that. We need young Black doctors. We need to support these kids from the beginning and tell them that it's possible for them to do so. We need to reach out to these kids before they get to the point of being in high school and middle school and have already been inundated with negative responses. We need to let them know that yes, you can be a physician. And that happens by seeing faces like ours in media. Now, as to how we can infiltrate the media and get our faces out there, you know, a lot of times it's for bad reasons, but I'll tell you, we've had a couple of our alums that have had the spotlight and have used the spotlight very well here recently. Dr. Elvis Francois, who was one of the recent graduates of Meharry Medical College, is about to finish his residency in orthopedic surgery, the singing doc. You know, he takes that opportunity, he sings, but he also talks about being a Black physician. And you know, he's utilizing his platform to spread that information. And one more doctor that I can speak to is Dr. Armand Henderson. Dr. Henderson works in Miami as an internist and works with the homeless community and was arrested for for no good reason. They said he was littering or something along those lines, some trumped up charge. But he did use his platform again to express basically what the mission of our college is, which is the worship of God through service to mankind. These doctors are out here living and breathing that. And, Dr. Hildred's mission is to increase that number. And we're doing everything we can to actually physically put these doctors out here in the community. But we also need the support of the community. And we need for those that are with us to have our backs. And generally they do. But to get a larger platform, we need a larger audience.
Okay. Dr. Smith, what concretely can people who are watching this do to support Meharry Medical College and the things that you're talking about? Just, is there anything that comes to mind?
Our chief cheerleader is here. So I'm gonna say what he probably would say is to give. Whatever you can financially, that's a big thing that you can do. Is to give to the college, but also to support the college in other non-financial ways. When we have events at the college, to support the college in the community, to be present, to send patients our way. We have fantastic clinicians that are seeing the patients in the entire Nashville community. We don't just serve the underserved in the community, but we do make it a part of our mission to serve the underserved. But we'd like to see more faces that look like us, because it's been proven that people who have a doctor that looks like them, that can relate to them, that grew up like them, have better outcomes. Yeah. And so I implore our community, I'm gonna keep it 100% real here. A lot of times in our community, we have problems with our customer service and how we treat people. And we're working on that diligently, but if you can't go on past reputation, and I can tell you that the people that come to my clinic get top class service, and it doesn't really matter what the clinic looks like. It's about the people that are in the clinic that are working to serve you. I've had patients that have come to see me, gone elsewhere, then come back because they miss that element of somebody who actually cared. And that's what Meharry is producing. And we're producing that all over the world. And so, I don't want to, Dr. Hildred is our chief cheerleader. That's our man. So I'm gonna let him talk more about that.
We're gonna give Dr. Hildred the last word. Now, the thing is, I wanted to say, Dr. Sessions, to pull on your point, and Mahisha and Sharizna, we do as pastors social crisis preaching. And before I write my sermon, I look to see what Dr. Hildred had to say. I'll pull up an article because I can trust Dr. Hildred, and I know that I can, and I don't even have to question the trust I have for him. And I'd like to have that for more physicians or scientists, but I know I trust him. So we want to just go around and do a final 2 minutes just to wrap up your thoughts. We're going to put Dr. Hildred last so he can get the final word. But so Dr. Session, if you'll go ahead and wrap up.
I just want to say that I want us to come together as a community. I want us to begin thinking about or rethinking what it means for us to live out our faith in community. And that means caring for each other. I think Dr. Smith used that language, right? That compassionate care, caring for each other. That means that I'm not going to go out into my community without my mask on. It means that I am not going to put other people at risk, right? It means that I am going to shelter in place, not because I like it, not because I want to, not because, it's so much fun in the house every day, all day, but because it is what is going to be most helpful for our community. It is Jesus' ethic of love. It's what it means to love neighbor as we love ourselves, right? Not just to love ourselves, but to love our neighbor also. And so loving neighbors means I'm not going to put my neighbor in harm's way. I'm not going to risk my neighbor's life to do something fun or frivolous just because I want to, right? So I want to challenge us to employ Jesus' ethic of love.
Yes. Mahisha.
Well, Spirit is surely moving in this place, because my message also centers around a coming together, centers around the we, our we-ness, if you will, and that there should be a lot less separation of a lot of things, right? So yes, more integrating into our community, and also not a separation between faith and between science, not a separation between movement and advocacy and our economy, not a separation between freedom and liberation and common sense and our elected officials. And I'm just going to name very quickly folks to get engaged too. So the folks that worked on the petition and the stuff that will come out, the toolkit, and that's Black Voters Matter. If you've never heard of these folks, they got a website, right? So the same way you need to go find these Black clinicians and these Black scientists and lift that up, these are areas and ways that you and your Blackness and your brownness can get involved. So Black Voters Matter, Highlander Research and Education Center, the Southern Rural Black Women's Initiative for Economic and Social Justice. That just sounds good coming out my body. And then the Southern Movement Assembly, who are in every way I can say my movement family. And I'm gonna close with this in talking about this separation. The comorbidity that is making Black folks higher risk, the underlying condition that is impacting our community is racism and oppressive politics and people and systems of oppression. So yes, we have health comorbidities, but we got systemic social inequitable comorbidities at place. And the same way the freedom followers follow Fannie Lou Hamer in saying we are not free until everybody is free, same way Dr. Irie Session is encouraging us to sacrifice our I-ness for our we-ness. Well, I'm gonna say that we are not immune until everyone is immune. We are not safe until everyone is safe. We need way more we in our beloved community. Thank you.
Thank you. So Dr. Smith, again.
All right. So I'm gonna be brief and just say, as an educator, I want us to learn something from this situation. When we don't learn from history, we're doomed to repeat it. And the Spanish flu of 1918 has basically repeated itself because we didn't learn from it. So I want us to learn from it, and the we-ness, man, Reverend Mahisha, I'm glad you mentioned we-ness, because we are all in this together. We cannot do it alone. So remember to reach out to your fellow man, to support people, call people, check in on people. You may be separated by physical distance, but we have so many means at our disposal now to get in contact with people, and even old-fashioned letters, whatever it takes. Communicate with your brother man, communicate truth and factual information, vet your sources, and learn from this situation.
Thank you. And Dr. James Hildred, we'll give you the final word.
Thank you, Reverend Caldwell. In the earliest days of the HIV pandemic, which is still ongoing, it was reported on the West Coast and East Coast that young white gay men were coming down with infections they should not get. And it was called gay-related immunodeficiency disorder. And the social and political construct at the time was such that because it was happening or perceived to be happening to gay people, no resources were made available to fight HIV because it was thought that those people were sinning, we don't have to worry about it, right? What I'm deeply concerned about is that it becoming increasingly clear that COVID-19 is devastating primarily brown and Black folks, given the political construct we're living in right now. Will that also then have the same effect it had back in the early 1980s and mid-80s for gayness and HIV? And what I'm trying to say is that we need to do what the gay men did back then. You might not recall this, but not getting assistance from the government or anyone else, they took it upon themselves to educate themselves, and the amount of HIV in gay men went down when in all the rest of the population it was going up, because they took action, they took it upon themselves to protect themselves, educate each other, and protect each other. And that's what we need to do, because I'm afraid that it becomes increasingly clear that we're the ones disproportionately affected by COVID-19. Will there be the same urgency had it been the other way around? So I'm urging us, we, to take it upon ourselves to protect ourselves. By that, we'll protect our community and minimize the devastation that this disease could have on us. And the urgency is real. I just need to have people understand that. The virus is all around us. It hasn't gone anywhere. All flattening the curve did was to make sure hospitals could take care of the people who were sick. It did not do anything to stop the spread of the virus. That's where the social distancing, the face covers, all those things come in. We must protect ourselves. We should not rely on anyone else to do it. And I'm urging, pleading, begging us to do that because this is real. We need to do the same thing for our people that gay white men did for themselves back when HIV was their problem, or at least people thought it was, when it was really everybody's problem. So that's what I'd like to leave everyone with, Pastor, is how urgent it is that we protect ourselves.
All right. Thank you, Dr. Hildred, and thank all the panelists for your insightful analysis. Also want to thank Reverend Charisma, Jean-Marie, and the Scarritt Bennett Center for putting this incredible conversation together. And she's asked me just to do a closing kind of word or prayer, if we will.
Rev, before you close out, I just want to go ahead and put out there, want to remind our audience, our community today, that 2021 is still an election year. It's still also census. If you have not filled out the census, is not too late. When you fill out census, what you're doing is allowing yourself to be counted. And we don't have any reason for government to count you in. The census allow for us to get the resources we need in our community. And the last thought for me is this: if you have not registered to vote, please register to vote. This year, if COVID-19 has taught us anything else, it's taught us that it is on us to save ourselves. We need to get to the polls and vote the best interests of our community. Thank you and God bless you.
Thank you, thank you. Let us pray. Lord, we just thank you for this time, for this gathering. We thank you that you've given us that through your salvation, that we are to participate and help to save ourselves by doing justly, by loving mercy, and by walking humbly with you. Lord, we thank you that this exposes the false separation that has been made between the body and the spirit, and that you are a holistic God who seeks liberation in every dimension of our existence. And if we separate our bodies from our soul, as we have done historically, we no longer have a body, but we have a corpse. But you have called us to be a living, breathing, animated representation of who you are in the earth. We thank you and we love you. It is in your name that we pray. Amen. Amen. Thank you so much, folks.
Amen.
Peace.
What a
So-
joy.
Yeah.
Thank all of
Thank you so
you.
much.
That body not a
Thank you.
corpse. Man, that got me.
Listen now, I went to the valley of the dry bones and I just got my help like right now.
Okay. Wow.
Woo.
Okay.
Thank you, everyone.
Thank you.
Thank
Dr.
you
you.
guys
Thank
so
you,
much.
Dr. Hildred.
Bye, everyone.
Thank you.
Thank you so much.
Thank you, Charisma.
Love to be a part of it again.
Hey, how you feel?
We
How you
still
feeling?
on live. We gotta hang up.
Oh, you know, I'm the therapist. You know, I gotta check in. How are you feeling? How's your heart, beloved? You know, this is.
Let me call you.
Okay, sounds good. Bye.